Yeah. Well, it has been quite a journey. I ended up talking with a guy named Rashika Fernandopouli, founder of Iora Health. He told me a while ago it's going to take you 10 years to get traction. And I'm now just past that 10-year mark, and he was right. Um, it's, you can have the right ideas. You can have a situation where we now have had 3,000 births in our practice, some in the hospitals, some in the birth centers. Transfers to the hospital happen. They're reasonable and necessary. It's been a challenge to get things paid for. I took a look at, your state there in Texas for the Medicaid system. The amount of money paid to a birth center for all-in care, facility fee, and professional fee is $1,800. And I know I was complaining that it was 4,500 for us. Now we've talked that the state systems, the departments of human service and whatnot, they're paying managed care organizations somewhere in the range of $15,000 to $20,000. Now, of course, neonatal care is necessary too. But all that to say, we've had all these births. It has been a real slog to make it work. I feel real obligated, though, to provide health care for our midwives. Some birth centers are only able to stay open because the midwives are like independent contractors, and it is a huge challenge. Everybody recognizes it. And I know you're big, Todd, in transparency. And I just think transparency, both on the commercial side and the public program side, will be really, really important because money is there. We've got all kinds of issues with healthcare disparities related to race. I'm very involved in that for a whole variety of reasons, but also on a national advisory committee for HHS. All these things could be solved, and the evidence is there that a different model of care would work, but it's still running. I describe it as I feel like I'm trying to push an iceberg with a canoe at a time. And I'm paddling hard, but I also see that the iceberg is either starting to melt, crack apart, or it is actually moving.
So if you think about it, the problem, the economic barriers to your success include the entrenched economic value that's realized by the hospital systems for NICU units and by existing physicians, OBGYNs who want to use the hospitals as the place where they deliver the baby. And so you've got this integrated and self-reinforcing model of negative cost pressure, meaning costs are going to continue to go up. It's going to get more expensive, and there's a better model out there, which you're actually delivering and have shown to work. In Dallas, as I know you know, we have a hospital called Parkland, which is very famous in your little sector of the world. Delivers about 12,000 babies a year, which is a pretty big number. And I think it's bigger than 10 states combined. I don't know which states, but it's a big number. And what's happening by virtue of what you just described is a little bit more subtle, because Medicaid is paid for by state and federal taxpayers, right?
Yes.
Parkland has a tax on all Dallas County residents that's equal to about 1/3 of our property tax. So what's happening is, by underfunding through Medicaid, Parkland Hospital is funding through the tax payments on our houses. Does that make sense?
It does. Well, I guess, in education, that happens a lot. I mean,
Sure.
that's one of the others, but, I was not aware of that. That's interesting.
So if I were to look at it, and one of the things I can go back to the county commissioners and have a chat with them about is say, hey, did you know that, because right now Parkland their gross billed revenues is north of $3 billion, and they only collect about 10% of that, which means that the remainder is funded through state and local tax distributions. So what's happening ultimately is that the local residents here are contributing perhaps disproportionately to the cost of maternity care by virtue of our tax payments and the underfunding of Medicaid you just described.
Yeah, I took a look at some of the, per member per month rates throughout the various counties in Texas, and every state is incredibly complicated because Medicaid is a federal state program. Every state is different, and even every portion of every state is different. But
Now, when you and I spoke last week, you told me something that was a stunning statistic. And it really surfaces for me right now as we're talking about this and the economics. Correct me if I'm not wrong. I mean, if I'm wrong, but I recall you having said that almost 50% of all babies born are born under Medicaid.
that's correct. All the way from some states, like maybe Utah, where it's 24%, to some states in the South where it's like 66%.
Wow.
So we're rapidly approaching half paid for by public programs. Now, in states like Minnesota, the federal poverty, I mean, the eligibility is like 275% of the federal poverty level. So some states like Minnesota and New York, Oregon probably are very, very generous. And I don't disagree that if you're going to spend money, that would be a good thing to spend it on. You just should be getting better value for the dollars spent, which kind of led me then to that birth bundle idea too.
Exactly. So let's talk about that. That's a nice segue into the birth bundle. Can you talk a little bit about that and what that means?
Right. So I did a little background research on, there was a few organizations commissioned a Truven study back in 2013 that looked at how much money was actually spent, not billed charges, but how much money was actually spent in a variety of states, commercial and public program, for maternity care. And it turns out it ranges, but in many places, commercial cost for a C-section and the pregnancy related to it, it's like $29,000. I mean, and it's definitely gone up since then. Medicaid payments are probably on the order of 11 to 12,000 for that sort of thing. So there's a lot of cross subsidization going on. And then when you dig deeper and say, where is the money actually going? Almost 2/3 of it go to facility fees for hospitals and for newborn care. And that's where the savings lie. That's where the fracking of the system can release actual value. When people say, "Oh, those physicians and midwives make too much money," that's only 20% of the overall spend. It really is facility fees. So I just started putting together a concept that we trademarked the name, the birth bundle, which is essentially a package of care from the prenatal care up through the intrapartum, so around the time of birth, and the facility fee for the birth center, also professional fees for the midwives. Our midwife team is able to attend births at our affiliated hospitals. So we do that. And we're also, because births are kind of fungible in general, they can move around in a community. We are also going to be working with our partner hospitals, and they will be our subcontractors for, if a mom needs to go to the hospital and needs care, she can do that. And then there's the whole aspect of neonatal care, which is probably almost 50% of the whole episode. That's where a lot of money goes down a dark hole at times. And a comprehensive team approach paid by as much of a single payment as you can get will get people to start working together. So it's not the anesthesiologist saying, "Hey, I need this much for my epidural," and the people who do what I do saying, "I need to be paid this much for the 5 ultrasounds we do." There definitely are times things really are necessary, but it's much better. And they're doing actually this in Kaiser, in the Kaiser system in California, where the physicians are paid a salary. They don't get extra for doing more work. Anyway, so that's why the birth bundle is really a single price for a real comprehensive episode of care. And we're trying to make it as comprehensive as possible. And it is getting a lot of excitement from payers. And ultimately, we all pay. Some of us pay because we make less money in the business that we work for, or the business that we own, or some are getting a bad deal because the taxes they're paying are really not paying for the highest value care.